Hello everyone. In today's lecture we are going to be talking about depression and antidepressant drugs. So what depression is, it is actually a feeling of sadness and hopelessness. In this condition, the patient actually feel inability to experience any pleasure. In any of his or her usual activities, and he can also have disturbance in sleep cycle or sleep patterns. He also experienced loss of appetite or change in appetite behavior. He also feel loss of energy, and there can be also presence of some suicidal thoughts. If we talk about the pathophysiology of depression, what actually happened that there is decrease in the concentration or production of norepinephrine or serotonin. So there is decrease in the concentration of norepinephrine or serotonin in brain, which actually result into depression. So this thing actually lead to a theory which is called as biogenic amine theory. According to this theory, it is said that depression is due to deficiency of these two monoamines at certain site of brain. But this theory is actually overly simplified, because after taking antidepressant drug, this thing is immediately recovered, but therapeutic response of the patient takes over several weeks. So it is suggested that reuptake of these neurotransmitter is only the initial effect of the drugs, but it is not directly responsible for antidepressant effects. So this bioamine theory is actually overly simplified, because reuptake of these neurotransmitters is actually immediately been recovered by antidepressant drug, but the therapeutic response of the patient for antidepressant effect is not directly stimulated. So what antidepressant drugs do is that they potentiate the effect of norepinephrine or serotonin directly or indirectly in brain, which in turn cause the increase in the presence of norepinephrine or serotonin in brain, which result into antidepressant effect. So this is how antidepressant drugs actually work. So we have different classes of antidepressant drugs, which are SSRIs, which stand for Selective Serotonin Reuptake Inhibitors. Selective Serotonin Reuptake Inhibitors. They actually inhibit the reuptake of serotonin neurotransmitter, and which result in increase in the concentration of serotonin in synaptic cleft. And the next class include serotonin norepinephrine reuptake inhibitors. They inhibit the reuptake of both serotonin and norepinephrine, and in this way there is increase in the concentration of these neurotransmitters in the synaptic cleft, which cause increase in the response of these neurotransmitters. And the next class is atypical antidepressants. And the fourth one is TCAs, which stand for tricyclic antidepressants. And the next one is monoamine oxidase inhibitors, which are known as MAOIs. So they actually inhibit the enzyme present for the degradation of serotonin or norepinephrine. So in this way they will increase the concentration of these neurotransmitter for the cellular responses. So today we are going to be talking about the first class, that is selective serotonin reuptake inhibitors. So these kind of antidepressant drugs actually specifically inhibit serotonin reuptake, and these kind of antidepressant drugs have 300 to 3000 fold greater selectivity for serotonin transporters than that of norepinephrine transporters. And these agents have less blocking activity for muscarinic receptor, alpha adrenergic, and H1 receptors. So this is the reason why they have less of the side effects. So in this way these agents have less adverse effects than that of tricyclic antidepressant, and they have different side effects than that of tricyclic or monoamine oxidase inhibitors, and are relatively safer in overdose. And these things make these agents drug of choice for treating depression. These antidepressants include agents like Fluoxetine, which is actually a prototype of this class. It also includes Citalopram, Escitalopram, Fluvoxamine, Paroxetine, and Sertraline. These all agents are included in selective serotonin reuptake inhibitors, and Fluoxetine is prototype of this class. And this Escitalopram is actually S enantiomer of Citalopram. So it is isomer of Citalopram. If we discuss about their working mechanism, if this is the presynaptic neuron and this is the postsynaptic neuron, so when the action potential arrives, there is release of neurotransmitter. Here is the release of serotonin. So what will happen? This serotonin is reuptaken by a transporter, and over here there is a presence of a transporter which causes the reuptake of this serotonin into the presynaptic neuron. So there is now presence of less neurotransmitter for these cellular responses. But what SSRIs do is that they cause the inhibition of this reuptake transporter. So in this way, there will be no reuptake of this neurotransmitter into the presynaptic neuron, and there will be more of the neurotransmitter present in the synaptic cleft. So there will be more of the cellular responses being going on in the postsynaptic neuron, because there is presence of receptors on the postsynaptic neuron, and neurotransmitter will bind to these receptors and cause cellular responses in postsynaptic neuron. SSRIs actually take at least 2 weeks to show their therapeutic response, that is improvement in mood, but maximum benefit require up to 12 weeks or more to show maximum benefit. Now if we talk about the uses of SSRIs, the primary indication of SSRI is depression. It is also used for other psychiatric disorders such as OCD, which is obsessive compulsive disorder, panic disorder, generalized anxiety disorder, and post-traumatic stress disorder. The stress which is occur after undergoing some trauma or injury. Other than that, it is also used in social anxiety disorder. This was generalized anxiety disorder, and this one is social anxiety disorder. Also used in premenstrual dysphoric disorder. Other than that, it is also used in bulimia nervosa, but only Fluoxetine, which is actually a prototype of this class, is approved for this condition, that is bulimia nervosa. So you cannot use other agent, or other agents are not approved for this condition. And what happens in premenstrual dysphoric disorder is that the patient feel extreme anxiety or depression or irritability before her period starts. So there is extreme depression going on a week or two before. If we talk about bulimia nervosa, it is actually a eating disorder in which the patient eat excess food, and then he has a anxiety, or he has a feeling of getting rid of that excessive food. So the patient get rid of that excessive food by unhealthy method, that can be induce vomiting, or that can be taking excess of laxatives. So this condition can be treated by Fluoxetine. So let's talk about the pharmacokinetics of SSRIs. SSRIs are actually well absorbed after oral administration. So well absorbed, and they are metabolized through liver. They have peak levels in blood in approximately 2 to 8 hours. And food has little effect on absorption except for Sertraline. Food can increase its absorption, so it is preferred to take Sertraline with food. And majority of SSRIs have half-life ranging between 16 to 36 hours. And they are metabolized through liver, through cytochrome P450 enzyme. And if we talk about the half-life of Fluoxetine, which is actually the prototype, so for that half-life is much longer because fluoxetine is further metabolized into one of its active metabolites, which is S-norfloxetine. So now, as it is also active metabolite, fluoxetine has half-life of approximately 50 hours, whereas its active metabolite, which is S-norfloxetine, it has half-life quite longer than the parent drug, that is fluoxetine. So it has half-life of almost 10 days, which is quite long. So it is available in sustained release preparations, which allow only once weekly dosing. So if we talk about the drug-drug interactions or contraindication of SSRIs, so fluoxetine, which is prototype drug of this class, or paroxetine, these two agents are actually potent inhibitors of CYP450 isozyme, which is CYP2D6, and this isozyme is responsible for elimination of various drugs. When this is being inhibited by these two agents, what will happen? There will be increase in the serum concentration of those agents which are being metabolized by this isozyme. So the agents which are metabolized by this isozyme are TCAs, antipsychotic, and some antiarrhythmics, and some beta adrenergic antagonists. These agents will be increased in body because of the decrease in the activity of this isozyme, which is required for the elimination of these agents. So this thing should be taken into consideration while prescribing these agents, that the patient should not be taking any of these agents if he is taking these SSRIs, because when there will be increase in the concentration of these agents, there will be obviously adverse effects showing on the patient. Another thing is that SSRIs themselves are metabolized by CYP450 isozymes. So the dosage of these agents should be reduced in patients with hepatic impairment or who have hepatic function compromised. So in such patients, SSRIs should be given in decreased dosage. So if we talk about the adverse effects related to the SSRIs, SSRIs can cause sleep disturbances. So Paroxetine and Fluvoxamine, both of these agents are actually sedating, more sedating than exciting or activating. These agents are used in those patients who are having sleep difficulty, whereas the patients who complain about fatigue, in such patients we can prescribe activating SSRIs, which are Sertraline and Fluoxetine. Both of these agents are actually activating rather than sedating. If we talk about the sexual dysfunction caused by these agents, so sexual dysfunction may include loss of libido, which is an urge for having sex. Other than that, there can be delayed ejaculation or anorgasmia. These are actually common adverse effects with SSRIs. So for managing this condition, we can change SSRIs with any other kind of antidepressant which have lesser sexual side effects, such as atypical antidepressant which have less of these effects, or we can decrease the dose of the drug to decrease this side effect. If we talk about the uses of antidepressant in children or teenagers, in them antidepressant should be cautiously used because in them antidepressant can cause or initiate suicidal thinking or can also worsen the condition of depression. So in patients having obsessive compulsive disorder, Fluoxetine, Sertraline and Fluvoxamine. These agents are approved for OCD, whereas for childhood depression, Fluoxetine and Escitalopram are approved. So both of these agents are approved for childhood depression. So we should always be monitoring the condition of pediatric patient because in them it can worsen the condition. Other than that, these SSRIs are also susceptible to cause anxiety and headaches, sweating, agitation, GI disturbances like nausea, vomiting and diarrhea, weakness, fatigue, changes in weight, but still these effects are much less severe than that of TCAs and MAOIs. So other than that, SSRIs are also associated with causing hyponatremia, which is decreased concentration of sodium ions in blood, especially in patients who are volume depleted or are taking diuretics. If we talk about the discontinuation syndrome caused by SSRIs, so SSRIs have the potential to cause withdrawal effects, which are particularly associated with those agents who have shorter half-life and have inactive metabolites, whereas prototype agent, that is Fluoxetine, has the lowest chance of causing any kind of withdrawal effect because first of all it has a very long half-life, that is about 50 hours, and second thing is that it is being metabolized into an active metabolite. So this is the second reason why it has less or lowest risk of causing withdrawal effect. But other agents which have shorter half-life, they can easily cause discontinuation syndrome, and discontinuation syndrome actually causes the patient to have flu-like symptoms, agitation, malaise is a feeling of illness without exact known cause. irritability, that is, a patient can be easily frustrated, nervousness, and sleep patterns are disturbed. These are some of the withdrawal symptoms which are caused when you abruptly stop taking SSRIs. Overdoses of SSRIs can cause seizures, and seizure threshold is lower by all of the antidepressant drugs. And if a seizure threshold is being lowered, it means that the person is more likely to have seizure. And if a person is having higher threshold for seizure, it means he is less likely to have seizure. So what these antidepressants do is that they decrease the threshold. In this way, the person is more likely to have seizures. Other than that, Citalopram is the only SSRI which can cause arrhythmia. SSRIs can also cause serotonin syndrome. And what is serotonin syndrome? It is actually due to presence of some other highly serotonergic drug. When there is excess of serotonin present inside the body or inside the brain, what will happen? There will be certain conditions being presented by the body, such as hyperthermia, muscle rigidity, sweating, myoclonus, which is actually a spasmodic jerk of a group of muscles. So it is actually twitching of clonic muscle. Other than that, there is presence of changes in mental status, and there is also presence of some changes in vital signs. So these are the things that can occur due to serotonin syndrome. And why serotonin syndrome is occurred? It is occurred when SSRIs are being taken along with any other serotonergic drug. So this was all about SSRIs. If you want to learn about other antidepressant drugs, you can go to my channel, and over there you can find other videos related to TCAs or SNRIs and other antidepressant drugs or classes. So thank you for watching, and if you have any questions, let me know in the comment section below.